Welcome back to the deep dive. Today's gonna be a little different. Usually we're looking at these big sweeping trends, AI taking over the world or the future of renewable energy. But today, we are zooming in way in.
We really are.
I have a stack of papers on the desk here that honestly, it looks like a police file, but it's not a crime scene report. It's a medical file. Clinical history, physical exams, radiology, all for one single patient.
It does feel a bit like a detective story, doesn't it? But instead of solving a crime, we're trying to solve a biological mystery. We're essentially conducting a forensic analysis of one man's medical journey.
Exactly. And the subject is a 70-year-old man named Abdul Khalik from Sukkur. And what really grabbed me about this case right from page one is how normal it starts. He didn't walk in screaming. He didn't come in an ambulance.
No, we walked into the outpatient department.
Right. And his complaint, a loose tooth, a sore in his mouth that just wouldn't heal.
Which is terrifying if you really think about it.
Why? I mean, everyone gets a sore mouth occasionally.
Because that's how the most aggressive monsters in oncology often hide. They masquerade as the mundane, oh, it's just a gum boil, or, I bit my cheek. By the time the patient realizes it's not healing, the war has already been raging for months.
So our mission today is to unpack this. We're going to follow the clues, the symptoms, the scans, the microscope slides to figure out what is actually eating away at Abdul Khalik. And then we're going to talk about the part that honestly kept me up last night, the engineering. How doctors plan to fix something that looks, on paper, completely unfixable.
The reconstruction aspect of this case is truly a marvel of modern medicine, where biology meets, well, heavy construction.
So let's meet the patient, Abdul Khalik, 70 years old. Vitals are stable. He's sitting there talking to the doctor. If you just glance at the stats, you think he's fine. But then you look at the history of present illness.
Right.
He says this started 4 months ago, an ulcer on the lower left gum. He says his teeth there felt loose. And recently, his face has started swelling up on that side.
Standard progression so far.
But then he says something odd. He says there's no shooting pain, no ouch when he touches it, really. But he feels a tightening of the skin on his cheek. Not swelling, but tightening. What does that even mean?
That is a very specific and very ominous description. When a patient says their skin feels tight or tethered, it's not just because there's a lump pushing it out. It usually means the tissue underneath is losing its elasticity.
Like it's being pulled from the inside.
Exactly, like it's being stitched together from the inside. The tumor isn't just pushing the skin, it's infiltrating the dermis, locking the layers together so they can't slide over each other anymore. It's a sign of invasion, not just expansion.
Okay, that is immediately so much worse than I thought. And then we get to the social history section and we find the culprit, or at least the accomplice.
The main 40.
Yeah, I had to look this up. It's a type of chewing tobacco?
It's more than just tobacco. It's a very potent, very dangerous cocktail. It's usually a mix of tobacco, areca nut, camphor, and this is the crucial part, slaked lime.
Slaked lime, like industrial lime.
Calcium hydroxide. And here's the chemistry of why it's so bad. The lime, it changes the pH level in the mouth. It makes the environment more alkaline.
And why would you want that?
Because an alkaline environment allows the nicotine to be absorbed much faster into the bloodstream. It gives you a quicker, stronger hit. But the cost is that the lime and the areca nut are incredibly abrasive and chemically caustic. It literally burns the DNA of the cells lining your mouth day after day for years.
So Abdul has been chemically assaulting his gums for decades, basically.
Precisely. And eventually the cells just snap. They stop repairing themselves and they start mutating.
And we see the result. The notes say that 2 weeks before he came to the hospital, a breach developed in the skin of his cheek.
That is the turning point.
Describe what that means, a breach.
It means the cancer started inside the mouth, on the gum, it ate through the muscle of the cheek, it ate through the fat pad, and finally it eroded right through the skin of the face to the outside air.
So he has a hole in his cheek.
Yes, an orocutaneous fistula, a tunnel from the mouth to the face.
That is visceral.
It's a sign of a very advanced, very aggressive process. I mean, the barrier between inside and outside is gone.
And on top of that, he's losing weight. He's not eating.
Well, imagine trying to eat when you have a hole in your cheek and your teeth are floating in a tumor. But the weight loss also signals that the cancer is metabolically demanding. It's stealing his calories to feed itself.
Okay, let's talk about the physical exam. The doctors are looking at him now. They describe a diffuse swelling covering the lower half of his face.
It's a large mass.
They measured it. It goes from the corner of his mouth almost back to his ear, and from his cheekbone all the way down under his jaw. That's half his face, isn't it?
It's the entire structural sidewall of the face, yes.
And looking at that hole, the fistula, they describe a pinkish exophytic growth with yellowish crusting poking out of it.
Exophytic just means growing outward, like a cauliflower. So the tumor is physically pushing itself out of the hole in his cheek, and the skin around it is described as indurated.
Indurated.
Hard, rock hard. If you touched his cheek, it wouldn't feel like flesh, it would feel like wood. That's the cancer cells packing the tissue so densely that there's no give left.
Okay, so that's the outside. Now the doctors ask him to open his mouth so they can see the inside, and he can't.
Grade 3 trismus.
What is trismus?
Lockjaw. He physically cannot open his mouth wide. This happens because the tumor has invaded the muscles responsible for chewing the pterygoids or the masseter. They're scarred down or spasming.
So the doctors are trying to peer into this tiny slit to see what's going on.
And what they see is a nightmare.
An ulceroproliferative lesion. Irregular, it looks like a wart, and it's necrotic.
Necrotic means dead. The tumor is growing so fast it's outstripping its own blood supply, so the center of it is literally dying and rotting while the edges keep expanding.
And the teeth. The file mentions floating teeth.
That's exactly what it sounds like. The bone of the jaw, the mandible, is supposed to hold the teeth in sockets. The tumor has eaten the bone away. So the teeth aren't anchored in anything hard anymore. They're just held in place by the gum tissue, essentially floating in this mass.
God. Imagine biting down and feeling your teeth shift because there's no bone underneath them.
It would be incredibly unsettling.
Now, amidst all this horror, there was one little detail in the neurological exam that I almost missed, but the doctors circled it. Diminished submental sensation on the left side.
Yes. This is the smoking gun for the staging.
Okay, explain this to me. His cheek is swollen, his gum is rotten, but why is his chin numb?
It's a geography problem. The mental nerve, which supplies feeling to the chin and the lower lip, it travels inside the jawbone. It runs through a little tunnel called mandibular canal.
Okay.
If the chin is numb, it means the tumor hasn't just eaten the top of the bone. It has drilled down into the center of the jawbone and invaded that nerve tunnel.
Yeah, so it's inside the bone itself.
Exactly. We call it perineural invasion. Think of the nerve like a fiber optic cable running through a subway tunnel. The cancer has broken into the subway tunnel and is now using it to travel.
Traveling where?
Backwards. Towards the brainstem, potentially. It uses the nerve sheath as a low-resistance highway. It makes the surgery infinitely more complicated because you can't just scrape the tumor off the bone. The bone itself is compromised from the inside out.
So clinical exam is done. They know it's bad. Now they need to see exactly how bad. They send him to radiology. You got an OPG, a CT, and an MRI.
The radiological deep dive.
So first, the OPG. That's the panoramic X-ray you get at the dentist, right?
Yes, and it confirms the floating teeth. The bone is just dissolved.
Then the CT scan. The report says the lesion is about 5 centimeters by 3.7 centimeters. That seems big.
It's the size of a lime in your cheek.
But the CT report says something worrying. Inseparable from the masseter muscle.
The masseter is the big muscle that lets you chew. Inseparable is radiologist speak. We're stuck to it. We're grown into it.
But then the MRI comes in. And the MRI seems to make things look even worse than the CT did.
MRIs are better at seeing soft tissue muscles, fat, tongue. The CT is good for bone, but the MRI tells the real truth about the invasion. And the MRI shows the tumor is actually larger, almost 7 centimeters long.
7 centimeters? That's significantly bigger.
It is. And the MRI lists the hit list of muscles. The buccinator, which is your cheek, your orbicularosaurus, your lips, the platysma in the neck. It's weaving through everything.
It also mentions the tongue muscles, but it says not crossing the midline. Why is that in bold in the report?
That's the one ray of hope here. The tongue is divided down the middle. If the cancer crosses that midline, it can easily spread to lymph nodes on both sides of the neck. If it stays on the left, we can hope the spread is mostly contained to the left side.
Speaking of spread, the lymph nodes, the end stage.
Yeah, this is the bad news. The MRI shows bilateral involvement.
Bilateral. But you just said...
Well, even if the tongue tumor didn't cross the midline, the lymphatic drainage can be tricky. Or the tumor is just so large it's found other routes. The report shows nodes on both sides of the neck are lighting up.
And how big are they?
The largest is about 3 centimeters, and it has central necrosis,
There's that word again. Dead in the center.
which means the metastasis in the lymph node is growing explosively.
Okay, so we have the map. Massive tumor. It's eaten the jaw. It spread to the neck nodes. Now we need the name of the beast. The biopsy.
They took a slice of the tissue, and under the microscope they saw nests and cords of cells.
And this phrase, keratin pearl formation. It sounds weirdly pretty.
It's a tragic irony of biology. These are squamous cells, skin cells. Their job in life is to make keratin, the tough stuff your fingernails are made of. Even though they've turned cancerous and are deep inside the cheek where they don't belong, they are still trying to do their old job. They're pumping out keratin. But because they're trapped in a ball of tumor cells, the keratin just piles up in the center, and it looks like a pearl.
So a pearl is basically a microscopic tombstone confirming it's squamous cell carcinoma.
Correct.
So let's tally the score. They stage him as T4A.
T4A means advanced local disease. It's invaded bone, skin, and deep muscle.
N3.
N3 is the worst nodal stage. Extensive spread to the lymph nodes.
And MX.
MX just means we haven't checked the lungs yet.
Huh.
But the notes say the chest CT was clear. So thank goodness it hasn't spread to his lungs or liver yet.
So he hit stage 4, but it's still considered curable.
Resectable is the word surgeons use.
Yeah.
Curable is, well, that's the goal. But we can get it out.
Okay, this is the part that blows my mind. The management plan. I'm reading this list of surgeries, and it sounds like they're going to disassemble his entire head.
It is a commando procedure. That's the old term for it, and it fits. It is a massive multi-team effort.
Step 1. Wide local excision. They cut out the tumor and a buffer zone.
Right, you can't just take the tumor. You have to take a centimeter of clean tissue around it to be safe.
Step 2. Segmental mandibulectomy. They are going to saw out a chunk of his jawbone.
Yes. From the angle of the jaw to the chin. Likely. Gone.
Step 3. A modified radical neck dissection. They slice open the neck and clear out all the lymph nodes.
They strip the jugular vein, the nerve, the muscles, strip them clean of fatty tissue and lymph nodes. It's incredibly delicate work because if you nick the carotid artery, it's game over.
Okay, so you've done all that. The cancer is out. But now you have a patient with a hole in his face, no jawbone on the left side, and a gaping wound in his neck. How does he wake up from that? How do you even fix that?
This is where the plastic surgeons step in. The plan calls for a distant-free fibular flap.
A fibular flap. Explain this like I'm 5.
Okay, well, one team is working on the neck, the second team is working on Abdul's leg, the lower leg.
His leg.
Yes, they make an incision and they locate the fibula. It's the thinner of the two shin bones.
Wait, doesn't he need that to walk?
Surprisingly, no. The tibia, the big shin bone, bears almost all your weight. The fibula is largely redundant. You can remove the middle section of it, and the patient can still walk perfectly fine once it heals.
So they take this bone out of his leg.
They take the bone, but crucially, they also take the artery and the vein that run alongside it, and a paddle of skin from the calf.
Okay.
They bring this piece of leg bone, skin, and blood vessels up to the face. They cut the bone into segments and plate them together to recreate the curve of a jaw. It's literally carpentry.
They build a new jaw out of a leg bone.
Yes. But here's the magic trick. A bone needs blood, right? If you just stick a bone in there, it will die. It will rot.
So how do they keep it alive?
Microvascular surgery. They take that artery from the leg, and under a high-powered microscope, they sew it into an artery in the neck. We were talking about stitching together tubes that are 1 or 2 millimeters wide.
That is insane engineering.
It is. If the blood flows, the leg bone becomes a jawbone. It lives. And the skin from the calf is used to patch the hole in the cheek or the floor of the mouth.
So Abdul wakes up and his jaw is actually his leg.
Correct. And if they need even more tissue, because remember he has that hole in his cheek, the notes mention using a pectoralis major flap.
The chest muscle.
They might peel up the chest muscle, leave it attached to his blood supply near the collarbone, and tunnel it under the neck skin to pull it up into the face, like pulling a blanket up.
The resilience of the human body and the audacity of these surgeons, it's staggering.
It is. But we have to be realistic. This isn't like fixing a car where you swap it apart and drive away.
Right, the recovery.
It's brutal. He will have a tracheostomy, a tube in his throat to breathe because his throat will be so swollen. He'll have a feeding tube in his nose, and he has to relearn everything.
Oh.
Relearn what? How to swallow, how to speak. His tongue muscles have been cut, his jaw is new, and doesn't have the same sensation. He has to undergo weeks of therapy just to drink a glass of water without choking.
And on top of all that, the cancer treatment isn't over.
No, the notes say adjuvant therapy is highly likely. Because of stage 4 and because the nodes were so bad, surgery isn't enough. There might be microscopic cells still floating around.
So radiation.
Radiation and chemotherapy, starting about 6 weeks after surgery. Just when he's starting to heal, they have to hit him with radiation, which causes more swelling, more pain, and dry mouth. It is a marathon of endurance.
You know, looking at this file, it started with loose teeth. and it ends with microsurgically attaching a leg bone to a neck artery. It really puts things in perspective.
It does. It highlights two things for me. First, the incredible redundancy and spare parts the human body has, that we can sacrifice a leg bone to save a face.
And second,
Vigilance. We talked about the Mainpuri, we talked about the numbness. If there's one takeaway for anyone listening, if you have a symptom that doesn't make sense, like a numb lip after a toothache, don't wait.
yeah, the tightening of the skin, the numbness, those are the red flags.
Abdul Khalid's journey is a difficult one.
Yeah.
But the fact that the surgery even exists,
Yeah.
that we can stage a T4 tumor and say, we have a plan, that is a triumph of science.
A triumph of science and a testament to a very tough patient. Abdul from Sukur, if you're out there, we are rooting for you. That's it for this deep dive. A bit heavier than our usual tech talk, but I think the engineering of the human body is the most fascinating tech of all.
Couldn't agree more.
Thanks for listening. Check your mouth, brush your teeth, and stay curious. We'll see you next time.